Welcome, everyone. Happy Thursday. Welcome to our Let's Talk Menopause Talk, Perimenopause 101 with Dr. Wen Shen. We are thrilled to have Dr. Shen here with us today and excited to introduce her and to dive right in. But at the top of this, I wanted to start with a brief introduction and a couple of housekeeping items before we get into it. So Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure that women get the information they need and the healthcare they deserve in midlife and beyond. I am Alessandra Henderson. I am the Senior Program Advisor to Let's Talk Menopause, and I'm so honored and grateful to be working with this incredible team on our educational programming. Um, these monthly menopause talks are central to our education efforts to ensure that you hear from the leading experts in the space who offer evidence-based information and resources. We do have a rich library of over 35, we might even be getting closer to 40 talks on our website. So if you want to go deeper on any topics, please check out letstalkmenopause.org. A reminder that these talks are intended for informational purposes only. They're not a substitute for professional medical advice, diagnosis, or treatment. And a huge thank you to our sponsor, Bayer, who ensures that we can provide this terrific information. Couple last housekeeping items. You might notice that we've disabled the chat. We're only using it to provide relevant links. If you have questions, whether you need clarity on terms or just want to go deeper on a particular topic, you should see a prompt on the right of your Zoom screen inviting you to participate in Slido. That's where you're able to ask questions or upvote any ones that you feel are particularly relevant. We do our best to answer these questions, but we really appreciate your patience if we don't get to yours. And a reminder to please not ask too specific or too niche questions. We really won't be able to go deep into the specific medical questions. Please try to ask more generalized. Last but not least, there will be a brief survey at the end. Please share your thoughts. We read every single one and take that to inform our programming. And you will receive a recording of the event. Okay, I think that's those are all the kind of housekeeping items, but I'm really excited to introduce Dr. Wen Shen, who will be going deep on all things perimenopause with us today. Dr. Shen is the Associate Professor of Clinical Gynecology at Johns Hopkins, where she serves as the Clinical Director of the Menopause Consultation Service and Director of the Women's Wellness and Healthy Aging Program. She earned her master's in public health and her medical degree from the Tulane School of Medicine and completed her residency in OBGYN at the Johns Hopkins Hospital. She has concentrated on menopause medicine for more than 20 years and specializes in treating perimenopause and menopausal symptoms through both hormonal and non-hormonal approaches that take into consideration a woman's overall health. Beyond her work as a practicing physician, Dr. Shen has published numerous articles and book chapters on menopause and premenopause, is a fellow of the American College of Obstetricians and Gynecologists, and has served on the board of trustees for the North American Menopause Society. So an incredible expert, and we're thrilled to have you with us today. I wanted to just start at the top of this by maybe hearing a little bit more about you beyond the bio, the path that led you into women's health, and perhaps a little bit about your care philosophy and how you approach menopause before diving into specifics.
Thank you very much, Alessandra. And thank you very much for inviting me. This is an honor for me to be speaking to your group, and also that Let's Talk Menopause has become so relevant. I hear about it and I hear praises about it. So great job to you and Donna. With regards to how I got into menopause, it's pretty straightforward, actually. So I was trained as an OBGYN because as a young woman, I wanted to deliver babies, right? I loved working with pregnant women. I loved delivering babies, and that was all tremendous amount of fun. And then I started noticing that a large proportion of my patients were perimenopausal, postmenopausal, coming in with those particular symptoms and issues. And I would, back then we were all still diving into textbooks to look for information. And there was very, very little research information on menopause. And that's when I realized that somebody had to do it. And so that's when I started to focus on the menopausal medicine. And it seemed like the more I learned, the more I needed to learn, the more the world needed to learn. And so I am very, very gratified to see that menopause is finally being taken seriously. And hopefully we'll be able to make advances and find out more information to better women's health.
Yeah. Well, thank you. I know you've led those efforts at Johns Hopkins and have been a leader in the conversation for many years. And so, with this actually September being perimenopause month, we're excited to dive into what feels like obviously a hugely important, but very misunderstood kind of
Yes.
phase of the menopause transition. So maybe I know you'd like to start with definitions. Um, maybe we could just start with very basic. What is perimenopause?
Right. So there is a lot of confusion. Patients come to me, and that very often is the question: Am I premenopausal, perimenopausal, postmenopausal? Am I done with menopause? So the first answer is once you become postmenopausal, you will always be menopausal. You will never be done because what being postmenopausal means is that your ovarian function has ceased. And so very, very unlikely, if ever, will ovarian function resume. Although there's a lot of research going on now, people who would like to keep ovarian function going for a much longer time, but that's not the norm at this point. Premenopause is basically any time before you reach menopause. So the entire reproductive lifespan that a woman has, where she is fertile, ovulating, her ovaries are working, she is defined as being premenopausal. Perimenopausal is it straddles between pre and post. And what perimenopause is when your ovarian function starts becoming more irregular. And so, not surprisingly, one of the most common symptoms that women who are perimenopausal present with is irregular menses. And they can also then start having menopause-like symptoms. So that would be hot flashes, night sweats, fatigue. And very often in the past, and this can happen anywhere, in a woman's 30s, all the way until the average age of menopause in the United States is 51. So but what has been happening is that women who were in their 30s and went to their doctor complaining of these symptoms, they were told, nope, you can't be perimenopausal, you're too young. So as a result, they were basically sent to another specialist or ignored or so, but yes, they can be perimenopausal. And perimenopause for many women would be just totally, except for irregular periods, no other symptoms. They're doing totally fine. Otherwise, you're just wondering why their periods that used to be clockwork all their lives, now all of a sudden, they're skipping, they're coming more, closely together. And so it behooves the woman to go to her OBGYN and be evaluated for that because there are other conditions that can result in that sort of irregular menses. And as long as the evaluation for those other conditions come out negative, then, and she's not having any other symptoms, she can just, keep an eye on her periods and wait and see how long it will last. And the other thing about irregular menses during perimenopause is that for some women, they will have really wonky, irregular periods for a while, and then it'll go back to being clockwork again. So perimenopause is when, there's just no predicting what the periods will do. They will do what they will do until menopause comes around. And so menopause is sort of an all-inclusive term, right? It includes peri and post. So the definition for post menopause is when a woman goes 12 consecutive months spontaneously without a period, meaning that she didn't have surgery to stop her periods. She's not on continuous contraception to stop her periods, that she's not on any other medications that can stop her periods. And so 12 consecutive months is the benchmark that we
Mhm.
use to identify a woman as being in post menopause. And that is the majority of the time. It's not something that is absolute. I've definitely had patients who went 12 consecutive months, and literally 1 week before that 12th month ends, they get a period. And you talk about women who are just frustrated and just so done with things, that would be it, because they've thrown out all their tampons and their pads and they thought, woo, I'm done. No. So the clock starts all over again at that point. So that's the general path of the ovarian aging. Now, what I had mentioned before about women who may have changes in their menstrual cycle, who may actually stop having menstrual cycles at an early age. Those are important things to consider and to get evaluated, because for women who have what we call premature ovarian insufficiency, so these will be women who stop having a period before the age of 40. These women, unfortunately, do have a markedly increased risk for a lot of medical morbidities, such as heart disease, osteoporosis, early onset dementia. So if a woman before the age of 40 stops having her period for 12 consecutive months, she definitely needs to be evaluated. And if she is in what we call POI, she needs to be treated and have that be addressed. And then other things that could also cause irregular menses would be young women with PCOS. And for women who do stop having a period before the age of 45, she doesn't have POI, but she would be considered as being having early menopause. And it
Okay.
would also behoove her to speak with her doctor.
Okay.
So those are the definition of the different stages, but they're not hard and fast. There's a lot of, crossing over back and forth.
Yeah. And what I hear, I mean, you said, thank you for walking through that. There are so many, it is complex. The uncertainty, like you said, can be incredibly frustrating, incredibly confusing. And I know we're here to dive into that further, but you said a couple of interesting things. I think that from POI, so the premature ovarian insufficiency, that is a relatively small percentage of women that have that, right? So,
Right.
uh,
So yes, that is a small percentage of women, thank goodness.
mhm,
But for those women, their condition can be very significant.
yeah. And so you also, if I could just maybe talk a little bit more about timeline, and you did say evaluation. If as a woman is experiencing either irregular periods or even some early symptoms that they'd like to check out, um, what hormones can they be testing? We get this question all the time. Is there a test? And how can I predict when I'm going to start to go through perimenopause and menopause?
Right. So if only we had a reliable test for that, right? So right now, if a woman is still having her periods but just irregularly, and if she is having all the symptoms of menopause, and if she is, especially if she's in her late 30s, in her 40s, it doesn't behoove us to do any kind of blood testing, because a woman who is in perimenopause is, as I said, her ovarian function is not regular, is not clockwork like it used to be. So depending on where in the irregular cycling of her ovarian function you do the testing, her hormones can be completely normal. They could actually be really high, and or they could be really low. So, at one point she can have low levels and then she's told, yep, you're postmenopausal, you're done. But she's still getting her periods. So we don't usually do hormone testing for women who are still getting their periods. There is one hormone that is very popular. I see it in lay press a lot, and that is anti-Mullerian hormone, AMH. That is not ready for prime time when it comes to predicting menopause. That is a hormone that the infertility um, physicians use a lot to evaluate the health of the ovaries and ovarian function. It helps them better guide their infertility patients as to what are the chances of success
Hmm.
for them going through the different treatments. So the answer to your question is no, we really don't have any suggested hormones to be tested. And yes, that is a very common question. A lot of patients will ask for me to send them for tests before they come in to see me. And my answer is usually, let me talk to you first. Let me see what else is going on.
Hmm.
And so I might either send you or not send you and have it be more pertinent.
Hmm. Okay. Um, and so we'll get into a bit of what that initial doctor or clinician visit can and should look like to make sure that women are getting the support they need. Um, but so if there is no test, perhaps what I'm hearing is making sure that we are taking note of our symptoms
Yeah,
and preparing as best we can by pulling together whether it's family history or symptoms or kind of coming in prepared with all of uh, the kind of environmental or experiential components to it as opposed to just looking at blood work.
right. Exactly.
There are a couple of questions. I think one thing also here, especially as women enter their uh, mid to late 30s and early 40s, as many women are on birth control, be it a oral contraceptive, an IUD that they might have had in for years, if not decades. Um, and so this is perhaps a two-part question. If a woman is in her early 40s or mid 40s, um, how can you tell if you're have irregular cycles, especially if you're on birth control? Maybe we can start there with what to do if you are on birth control and you're trying to understand where you are in your cycle. Excuse me,
Great
not cycle,
question.
but menopause transition.
Right, right. Especially now that there are a fair number of women in their 40s who are on oral contraceptive pills or even the contraceptive injections or the IUDs, which really stops the menstrual periods altogether. So they really don't know
Mhm.
what their periods are doing. And if the contraception is working, they're not having side effects, and they're not having menopausal symptoms, then I say, don't mess with it. It ain't broke, don't fix it.
Yeah.
And wait until you are closer to 50 when you can start thinking about coming off of the birth control if you are menopausal. But chances are, if you're in your early 40s, mid 40s, you are still reproductive. And so you need the protection. Additionally, when you are perimenopausal, oh, so this is one thing I should address. Perimenopause is probably when a woman will have her worst menopause symptoms because of the peaks and valleys of her ovarian function, her hormone levels. And so this is when most women will have the hot flashes, the night sweats, the sleep disturbance, the mood changes, the irregular periods that come and go as they will. So, and the brain fog, the fatigue, shall I go on? Sounds horrible. Um, so yeah, I get perimenopausal patients coming into me and their eyes are rotating in different directions, and their first sentence out of their mouth is that, "Doctor, I think I'm going crazy." And so, yeah, perimenopause symptoms can do that to you. And so actually by being on continuous oral contraception, can stabilize the hormone levels and can actually help control a lot of those symptoms that happen to perimenopausal women. For women who are not having the other systemic symptoms and their primary perimenopause symptom is abnormal periods, then the hormonal IUD can be very, very helpful because not only is it contraception, it also helps stop menstrual periods in 80% of women who are on it. And the other women normally have a much decreased amount of bleeding on the hormonal IUD.
Mm.
The injection hormonal contraception is also meant to prevent bleeding, prevent periods, and so that can also be of help. So the only item about the injection um, progestin contraception is that it can cause mood changes, which is already an issue for a lot of menopausal women. And the other item is that it may increase a woman's risk for bone loss. So
Mm.
osteopenia, osteoporosis, if she is on it long term. So my main go-to for perimenopausal women is either the hormonal IUD or the ultra low dose um, birth control pills.
Mm. So it's interesting. It's multiple different strategies, timing, and reasons why you might be on it. So one,
Right,
just to double down on it, like you said, you can still get pregnant in
right.
these years, and some women can be surprised. So contraception is still important.
Yep,
Um, Two, if you are on it, it sounds like why mess with it, like you said. And so rather than trying to figure out where you are in your cycle going off and on, to stay on it until closer to 50, and then you can start to assess and work with your provider.
exactly.
And then third, to your point from a call it treatment perspective, I know there's a lot around menopause hormone therapy, and we'll continue to expand on that and what you can do for symptom management, but you do even recommend uh, hormonal IUDs as well as oral contraceptives to help with symptom management. So, well, many different uses here.
Yeah, exactly. And um, Yeah, so for perimenopausal women, we need to consider not just her menopause symptoms,
Hmm.
but her fertility and her desire for fertility or not. And for a woman to become pregnant while she's perimenopausal in her beyond the age of 45 does carry risks. It's not just, oh my goodness, I'm pregnant. I thought I was past that. What am I going to do? But it's also that the fetus is at increased risk for chromosomal abnormalities. And actually, the woman herself is at increased risk. About 50% of these pregnancies will wind up in miscarriages.
Hmm.
So, and the woman, if she does decide to carry through with a pregnancy, she would be at increased risk of having preeclampsia, gestational diabetes. So it's just a whole list
Okay.
of things to consider.
Yeah. Uh, does this and talking just especially as we're understanding what phase you're in and symptoms, there are a couple of questions which I might try to blend together of questions around, women who have had either partial hysterectomies, PCOS, endometrial ablation, kind of it does perimenopause, I suppose, show up differently, and if you have different um, um, conditions, or I know that that's mashing together a lot of different areas, but how do you consider perimenopause across women who have had different uh,
Sure,
gynecological conditions?
sure. So menopause, as I defined it, has to do with your ovarian function. So if a woman had only a hysterectomy, meaning that she had her uterus removed, usually most common cause is abnormal bleeding, fibroids, endometriosis. She does not have to be menopausal. She still retains her ovaries. So she can continue to have ovarian hormone production. However, we do know that women who have had hysterectomy can have earlier menopause, even though they still have their ovaries. So it is something to keep in mind, even if you're not yet 50, 51, but you've had a hysterectomy and you're having those symptoms, it would be good to discuss that. That is one situation where getting a hormone level can help, okay? Because we can't tell by your periods, you don't have periods. So getting an estradiol level, FSH level sometimes can help us know about your ovarian function. So that is one place where we can use those hormone levels to help define things. And then with regards to women who have had PCOS, that is menopause is also very important because we know that having PCOS increases a woman's risk for many medical morbidities, diabetes, high blood pressure. So it's something that if she is going into her menopause years, she would also need to be very closely observed, and if she is having symptoms, being on hormone therapy to help control her symptoms, but also prevention is a very important part of perimenopause. One of the reasons why I really like doing consultations on perimenopausal women is even if she walks out of my office saying, okay, I'm good, I don't need to do anything. So why did I have to take time to come in and talk to you? And the reason for that is we've reviewed any risk factors you might have, and I will usually let a woman know what sort of preventive steps she should take, what she should be looking out for, and what she should do as she ages. And obviously come back if she starts developing more symptoms. So that PCOS will be one of those. Okay. And what was your third item?
I think endometriosis, hysterectomy, PCOS.
Right.
I think those trying to capture most of what people mentioned as well.
Right. So with endometriosis, that can be a bit tricky. Usually for endometriosis surgeries, um, the final definitive surgery after everything else has been tried, usually. I know our GYN minimally invasive surgeons are very conservative about doing hysterectomies and removing the ovaries for endometriosis. Usually it's after they've tried um, lesser surgeries, after they've tried medical options, just because making a woman surgically postmenopausal is pretty devastating for a lot of women. And so if a woman does end up with that total pelvic clean out because her endometriosis just could not be controlled otherwise, then yes, she will usually need to be, because she will go into surgical menopause. One day she's premenopausal, next day she's postmenopausal. So she will usually have quite severe menopause symptoms and will need to go on hormone therapy. And usually for women with history of severe endometriosis, there needs to be very careful titration
Hmm.
of her hormone doses, but then there are also non-hormonal options that can be discussed that will not trigger any remnant endometriosis she may have.
Perfect. Thank you. So I'd love to touch on a bit of what that doctor visit looks like, and then we can expand, as you mentioned, on some of the additional treatment options beyond that we've mentioned. So, just, what, very basic again, but what kind of doctor, how does a woman find the right expert, and how does she prepare for that visit to maximize?
So one of the things that I am teaching, and also my co-director for my program, Dr. Tina Zhang, who is an internal medicine doctor. So for menopause medicine, it is not the entirely in OBGYN. We are collaborators with our internal medicine colleagues. And, besides general internal medicine, there's cardiology, there's metabolic bone, there's psychiatry, there's any number of different specialties that are so important for a woman's menopause symptoms. And so, and my first visit with a patient who comes in for consultation will take all of that into concern. So I usually start out reviewing a woman's medical history, and very often I'll get a question like, why are we going through all this? I'm here for my hot flashes. And so I said, well, I will come back to your hot flashes and your night sweats, but I want to be able to advise you in the safest manner possible. And in order to do that, I need to know what your medical history is, because you are a lot more than where you are now. You are a conglomeration of all of your medical um, history from the time you started having periods. So I would start with their obstetrical history, because we know now that women who had had preeclampsia, pregnancy-induced hypertension, placental abnormalities, gestational diabetes, all of these pregnancy-related conditions are at increased risk for heart disease and having heart attacks after menopause. Okay, they've done perfectly fine, very healthy, but when their estrogen supply runs out over the course of the 10, 15 years after they stop having a period, their heart disease risk starts building and they wind up with a heart attack at 65. There's also the risk for osteoporosis. If a woman has a history of asthma and has been on steroids all her life, we know that steroids eat up bones. And so we don't want to find out that she has osteoporosis when she breaks her hip bone, because we know women who have a vertebral or a hip fracture because of osteoporosis don't recover. It's not like when you're young and healthy and you break a leg skiing. This is not that. This is fragility fracture, which is very, very difficult to recover from. And then also thing that's on everybody's mind, right? The mind. Um, so there is some evidence, although we're not going around saying definitively that menopause hormone, that estrogen can help with cognitive function. But Dr. Moskowitz in New York has done so much research, and I think, your audience, have you all invited her yet?
I don't believe so, or at
You
least
need
not under
to.
my time.
You need
Send
to.
it to, yeah,
She
we'll
has
make sure to
done,
follow up on that.
yeah, she has done amazing research
Okay.
on menopausal and brain. So after having, and also family history, okay, I know I'm taking forever on this, but so family
No, but
history,
this is the complexity of a visit. This is why this isn't a 7 minute,
okay,
surgical
all right,
visit. You're out the door. You're one
right.
later.
So if a woman tells me that a first degree relative had a heart attack before the age of 65 in a woman and before the age of 50 in a man, okay, then she is at increased risk for heart disease. If a woman has a family history in a first degree relative of fragility fracture, she is at risk. So all of these issues would prompt me to refer her for a consultation with my colleagues, and just for them to do some further testing to see if they are, so the cardiologists will run these different specialized lipid levels, and the psych um, people would, evaluate for risks of dementia. And so all of these things that would really help guide the woman to a healthier aging, because women are in the United States are now living into our mid 80s, right? And menopause happens around 50. So that is over 30 years of living in either good health or in severe debilitation.
Mhm.
So prevention is a huge part of my consultation with patients. And then after all that, I'll come back to why she's coming in to see me. And all she wanted to do was get something for her night sweats so that she can sleep.
Yeah. And we'll get into treatment in 1 second. The other big area I just wanted to quickly touch on too, because they're both questions, but it also is an important part of this too, is the sexual health component as well. We hear from women with increased UTIs, pain with sex, dyspareunia, which maybe you can define. There's pretty challenging words for what can be a challenging period in a woman's life too. So maybe if we could just touch quickly on the GSM, and I'll leave it
Right.
to you to define that for the audience as the expert, that those
Right.
symptoms are very real and part of this transition as well.
Absolutely. And that's very, very important for a large number of patients. GSM stands for genital urinary syndrome of menopause. And we used to just call it vaginal atrophy, vulvar atrophy, but it's something that really is due to low estrogen levels and its effects on the whole urogenital area. So that includes the bladder, the vulva, the vagina, and also the cervix and uterus. And so the atrophy just means the lack of estrogen will thin out the skin in the vagina, the vulva, and the bladder. And when the skin thins out, it doesn't stretch. And if the bladder skin doesn't stretch, you end up with limited bladder volume. And so older women are always having to run to the bathroom or have mild or even severe urinary incontinence because of that. And also because of the thinness and there's a certain lack of protection of from the microbiome. And there is also a change in the microbiome so that, and there's a change in the pH so that some older women may end up with recurrent urinary tract infections. And that at first is just a nuisance, but as a woman ages, unfortunately, some stop feeling the symptoms of a UTI. And so I've had patients in their 70s and 80s who were admitted into the hospital for sepsis and for kidney infections that all started as a urinary tract infection that they didn't actually feel. So it's a lot more than just a case of minor discomfort with a bladder infection. Okay. And then with regards to the vulvar and vaginal atrophy, that basically makes sex feel like paper cuts. And some women do bleed after sex because the skin is just so thin, not stretchable, and gets torn during the process. And so you wonder why these women don't want to have sex, you know? So it's something that is so easily remedied. It is something that, thank goodness, recently the FDA has considered changing that black box warning on, and I think Donna Classen has had a lot to do with getting, the FDA to listen with regards to changing the black box, because a lot of women got scared away from using ultra low dose vaginal estrogen because of that black box saying you can have a stroke, you can have breast cancer, you can have this, that, and the other. Whereas the reality is for women who are on the vaginal estrogen as prescribed have almost no increase in their blood level of estrogen. So in other words, there is minimal to no absorption of the estrogen that is applied to the vulva and the vagina for those purposes. And that can so much improve a woman's quality of life, right? First of all, she's more comfortable. She can sit in a chair for a while without, having the vulva be totally irritated. And she can have sex and she can have, relationship with her husband or a partner. And so these are items that are very, very important for a woman's quality of life.
Yeah. Well, you took the words right out of my mouth because I was going to get to, it sounds like in that both first visit, we know we can't solve everything in one visit, but just as you work with women over time, you talk about not just short-term symptom management, but long-term preventative care, which is incredible. And so Donna has linked in the chat, if you are looking for an incredible provider like Dr. Shen, there are amazing providers who are certified in menopause medicine. So please take advantage of that resource that Let's Talk Menopause has put together. But I did want to spend some time because I know we have a little less than 10, 15 minutes to continue to talk about treatments and how to feel better, right, with symptom management. So you did cover a lot around IUDs and birth controls and just now local vaginal estrogen. But there are some questions, and I still think there's some confusion in perimenopause of, am I going on MHT, menopause hormone therapy, or am I going on hormone therapy or am I going on these birth control or IUDs? So how do you assess what a woman can ask for or expect if taking the hormonal route, and then we'll go the non-hormonal route?
Right. So some more definition. The accepted terminology for menopause hormone therapy is menopause hormone therapy, MHT. We don't use HRT, which is an old term that used to be used. HRT stands for hormone replacement therapy, and that's not really what menopause hormone therapy is about. Additionally, HRT is now a term that is used for the transgender treatments for people who are transitioning from one sex to another, and so they use HRT. So we don't use HRT. With regards to MHT, it could be estrogen alone if a woman has had a hysterectomy. It could be progesterone alone if a woman, for certain symptoms and she doesn't need to be on estrogen. So they can be separated out. Whether a woman should be on birth control pills versus menopause hormone therapy, the old oral menopause hormone therapy were very similar to the birth control pills. They were synthetic hormones, synthetic estrogens and progestins. And synthetic estrogens and progestins do carry a certain amount of risk with them, but they are much stronger than the menopause hormones. And they, for a younger woman who needs to be protected from pregnancy, we want that stronger hormone to be working. And so that's why the recommendation is for a woman to stay on her birth control pills until such time she has been shown to be postmenopausal. Okay, just for protection, and also helps with her symptoms. Once a woman becomes postmenopausal and does not need contraception anymore, then we convert her over to menopause hormone therapy. So, I mean, there's a lot of if this then that's, right? So people who see patients after I've seen them, they get very confused about the combinations that I have people on, because it very much depends on what the woman's specific. So if, for example, a woman is peri or even postmenopausal, but she still has a functioning hormonal IUD in, okay, then she can go on estrogen only therapy. If she's premenopausal, the hormonal IUD prevents contraception and also helps protect her endometrium from the stimulatory effects of the estrogen. And if she is postmenopausal, but her IUD is still good, my advice is usually it's good, it's been working for you, you don't have any side effects. Let's keep it in until it runs its course, and we'll just add on the estrogen for, to help with all of your symptoms until such time. And then the other thing is the menopause hormone therapy that we use nowadays is very, very different from the old oral synthetic hormone therapy. And not all estrogens and progestogens are created equal. So that the estrogen that we use now is 17-beta estradiol, which, if you look up its chemical structure, it is the exact same estradiol that your ovaries make, except that it's not coming from your ovaries, it's coming from a nice skin patch or a skin cream that you apply. The progesterone that we use is the natural micronized progesterone. Again, the exact same molecular structure. So even though these hormones are synthesized in a pharmaceutical laboratory, they are bioidentical. Okay, so a lot of people have the misconception that bioidentical means that they have to eat, 10 pounds of yams a day. And good luck to you for that. But when you can just have this little patch that you slap on your abdomen or buttock, and it provides what estrogen, natural estrogen that you need. So that is what I advise patients about the different options for hormone therapy around perimenopause. You can go continue your contraceptive options, or you can change over to menopause hormones depending on what your situation is.
Yeah. Wow, the complexity of it, like you said, is very real and just drives home the importance of finding a provider who is an expert in this space. With the last perhaps couple of minutes here, if we could talk about a little bit about those non-hormonal treatments, either prescriptions, lifestyle, even supplements, however, wherever you'd like to start with those, especially those who are not able to take hormone therapy because of family risk factors or personal factors.
Right. So the most exciting developments over the past few years has been the candy inhibit, what we call, so KNDY are neurons in a woman's brain that carry the neuro transmitters that are involved in hot flashes. And usually these neurons in a premenopausal woman are very well controlled by a woman's estrogen. And when her estrogen level goes down, these neurons go bonkers. And so they start causing all kinds of havoc with temperature control. And so the two products that are available now, one by Bayer, one by Astellas, that can help control those neurons, get them back in line again, and so can significantly improve a woman's problems with hot flashes and night sweats. Okay, so that's what they are primarily prescribed for. Um, but obviously, with as contrasted to menopause hormone therapy, there are certain reasons, if we're also considering a woman's bone health, her brain health, heart health, then the hormone therapy started at an early menopause age would be better. But if a woman has breast cancer, those are hormones are not options for her. And so then these non-hormonal options are a lifesaver for them. And so luckily there are these different options available. Lifestyle, the evidence has been very, very back and forth, right? There have been studies that show that mindfulness really helps. There are studies that shows Tai Chi. And what I say about that is we don't have hard and fast evidence that they work, but they're good for your health. So do it. Whether they work for your menopause hormone, your menopause symptoms or not, they're good for your health. I think in this day and age, we all need a little mindfulness. And so that is another option. What also has been of interest lately has been CBTI, so cognitive behavior therapy. There has been some early evidence that helps women with mood symptom, which is a real problem for a lot of women in perimenopause. And we've done a pilot study with the psychiatrist Lisa Hansu at Hopkins, and we're going to be publishing a paper on our findings. And that's also good because it's no medications needed. You just get 8 sessions of helping how to work yourself through when you feel that you're losing control. So it's CBTI. And then another non-hormonal option, which is a bit more challenging to accept, is called stellate ganglion block. And that is Yeah, my patient's eyes are ready to go. So stellate ganglion
You have to
is,
write that one down,
yeah,
definitely.
so it's a bundle of nerves in the neck at the root of the skull, and it's a block that's usually applied by anesthesiologists for people who have pain syndromes, for people who have different. But lo and behold, people who were getting those blocks for migraines found that their hot flashes got better. And so there's thought to be some sort of a feedback loop that works. But obviously, most insurance companies are going to push back on that. And there aren't that many anesthesiologists who are comfortable doing that. That is something that our pain center at Hopkins, with anesthesiologists who do pain treatments for every known condition, are more comfortable doing.
Mhm. Okay. And I know there's a range of like because perimenopause and menopause is everywhere, or seemingly at least on my feeds and my news
Oh,
and
yeah.
cycles. There's a lot coming women's way in terms of protein and strength training and sleep and what supplements to use. And unfortunately, we only have 2 minutes left, so I'm sure we won't be able to cover that. But we will have our next talk is actually on sleep, which I know Donna had listed here. And we have been planning out our 2026 calendar for these talks, looking and going deeper into non-hormonal treatment options. And just, again, there's so many symptoms and so many misconceptions as well as evidence-based solutions.
Right.
So um,
Right.
but because unfortunately we're out of time here, we thank you so very much. I want to, if there's anything, I know we ended on the treatment options, but if there's any final words that you do recommend for women navigating perimenopause, would so love to hear them here.
So my program, we do have a website. It's WAP, WWHAP. Don't ask me. The naming people at Johns Hopkins made us give that name. So it's Women's Wellness and Healthy Aging Program, Johns Hopkins. Go to the website. We have a lot of information. And also, we have other podcasts that members of my group have done. There, I believe we also have some information on there from, I won't name another organization that actually listed um, all the academic menopause programs. So I feel that the academic programs tend to be evidence-based, right? And so that would be a better place to go to find a provider. And also other places to find providers would be to look up women's health fellowships. So there are very few. We have one of the few women's health fellowships, which are internal medicine providers who finish their residency and are doing 2 additional years of training specifically on women's health. So,
Thank you for what you're doing to not only help the women in your program, but also to train residents to champion the space and to continue to move research forward. This has been an incredibly informative talk, and happy perimenopause month. Thank you to everyone who attended here. And obviously a huge thank you to Dr. Shen for sharing her wisdom. Um, it's 101, so we will let everyone jump. But there is a survey in your Zoom, so please fill that out. We take every single comment to heart. We really appreciate your feedback. And then, as I mentioned, we do have our next talk, which is next month, World Menopause Month, on October 16th. Tired of being tired. Talking sleep strategies with expert Dr. Shelby Harris on October 16th. We do hope you'll join us because sleep is the cornerstone, oftentimes, of health. And so, an important and one of our top 5 most requested topics from our community. So, thank you again, Dr. Shen, and please
my
fill out the
pleasure.
survey. And we hope everyone has a wonderful afternoon.
Bye.